My name's Hamish Eldon from HealthCert. On behalf of HealthCert, I'd like to welcome you this evening on today, the 7th week. I think, David, I counted. It seems it's gone very quickly for our COVID-19 clinical update. Just a bit of housekeeping for everyone. In the Zoom window, you'll find down the bottom a little Q&A panel. Please feel free to type in some questions as you go through, and then at the end of David's presentation, we'll go through those questions. I think on the iPad and on iPhones and others, the button's up the top, so please feel free to type away as we're going through, and we'll address them at the end. David, do you have any slides? Do you need to get your presentation up?
There we go.
All right. Well, I'll let you get started. Welcome, David.
Thanks, Hamish, and good evening, everybody. It's nice to see everybody again, and greetings from a very wintry Sydney, or relatively speaking, wintry Sydney. It's really quite cold here today for the first time for a little while. It's a pleasure to be with everybody again. As usual, I've got a handful of slides. I'll walk you through them quite quickly. And we'll keep doing these updates as long as they are useful. So please do send feedback or give ideas on what focus you would like there to be each week. And I'm happy to do my best, because I spend a lot of time, because of my role at the university, making sure that we're fully abreast of everything that's going on with COVID. So here we go. This is my take on the week. And as Hamish indicated at the start, it's amazing how much is happening and how quickly it's all happening. So my first slide, as usual, is the count of new confirmed cases every day in Australia. And the story is the same as it has been for quite some time now, with very small numbers of cases each day. I think it was 1 in New South Wales this morning. Very small numbers around Australia, many states and territories with no cases, and most of the cases are now well identified outbreaks and clusters. One is in an abattoir in Victoria, and there's another one, a very nasty outbreak here in New South Wales in an aged care facility. I think it's 14 deaths in the aged care facility. But there is now very little if any, community transmission in Australia. So this phase of the epidemic certainly is over. I've shown you this kind of slide before. I've only included the 3 big states, New South Wales, Victoria and Queensland, because in the other states, as you would be aware, states and territories, the numbers are now vanishingly small. And as you can see, even in New South Wales, Victoria and Queensland, the numbers are very small indeed. And apart from the 2 outbreaks that I mentioned in Victoria and New South Wales, there really is not much going on in terms of new cases. Here's a bit of an update on how we are comparing in terms of number of cases around the world. I draw your attention again that the y-axis here is a log scale. So this is a 10-fold increase in the number of cases between the lines here. So this is 1,000 here, this is 10,000, this is 100,000, and this is 1 million. You can see the US is right up here, and it's the slope of the curve that really matters. The US is still growing, the UK is still growing, even Italy is still growing, China, New Zealand, Taiwan, Australia, South Korea, all flattened out. Singapore is bringing its epidemic under control, as is Japan. But again, as we're all conscious now, Australia and New Zealand, Taiwan, low numbers, and the epidemic with the flat curve very well under control. We spoke a little bit last week about some of the rumors around the origins of COVID-19. I've done a little bit more research into this. Here's a great paper in Nature Medicine, published a couple of weeks ago, talks about the genetic origins of SARS-CoV-2 And despite some of the nonsense that we hear in the press, if you look at all of the scientific peer-reviewed literature, and I was on a webinar with Professor Peter Doherty, the Nobel Prize winner in Melbourne today, and the consensus around the scientific community is that COVID-19 is not a man-made virus. It could have leaked from the Wuhan virology laboratory, could have been released, but it looks to all of the people that know these things like a naturally occurring virus. There's been a lot of work going on recently, as again some of you I'm sure have heard about now the roadmap out of COVID-19, the roadmap to recovery. Of course, what's happened in Australia, as has happened all around the world, is basically the economy has been shut down. We've all been told to stand still and stay at home as much as we can. And this has had obviously a catastrophic effect on the economy, and many people's lives and employment has been very badly affected. One of the groups that has been helping the government figure out the way forward is the group of 8 universities in Australia, and the National Cabinet has now adopted their option 2 controlled adaptation strategy. It's worth being aware of the components of this because we're all going to live through this over the next little while. Basically, as you can see here, and you can read the detail later, this strategy allows restrictions to be lifted in the middle of May. And as we know, National Cabinet is meeting tomorrow and Friday, and I think there is an expectation of some fairly significant announcements this week about easing restrictions. The second dot point basically says we have to start preparing to live with the risk of ongoing COVID at a low level, with outbreaks, and with a health system that is ready to react to it. And that's dot point 3. Dot point 4, we have to accept that there will be more cases, more hospitalizations, and more deaths. But the plan is that they will be proportionate, very small in number. Nothing like even a bad flu season is the kind of thinking, but that this will be an ongoing infection, even in Australia, even in New Zealand, but at very low levels. And the key to this, and this is in dot point 5 in the second column, is extensive testing and contact tracing. And this has been central to Australia's success, central to New Zealand's success. It is fair to say, and Professor Peter Doherty from the Doherty Institute in Melbourne did say this today on his webinar, and he has the authority to say this, Australia got very lucky. We closed the borders early. We had a low circulating background number of COVID cases, and we got lucky. So we have to make sure we stay lucky, and we stay lucky with extensive testing, really tight contact tracing, and we will have to accept the need for strict social distancing and extensive personal hygiene. So worth having a look through this carefully at the end of the webinar. The full document, which is very short and readable, is available on the Group of 8 website for those of you interested. It's worth having a look if you feel you have to plan your and your work future a little bit better. We also had questions during the week about details of the clinical picture of COVID-19 and treatment, because even though most of us don't have a role in that, because we have small number of cases now in Australia, and many of them severe cases are treated in hospital. If you are interested, this apparently is one of the very best sources, the Brigham and Women's Hospital website. This is a web page that is being updated daily as new information comes around from all around the world. And essentially this is becoming one of the best sets of clinical practice guidelines. So for those of us interested in the clinical manifestations of the disease, this is well worth a look. I draw that to your attention. Of course, everybody's interested in vaccine, and we're seeing stories in the media every day about vaccine trials having been started, people claiming there'll be a vaccine by September, and then somebody says it's next year, and so on and so forth. Here is a bit of an outline for you from the New England Journal of Medicine. And at the top here, on the top half of this slide, this is how a vaccine is usually made and why it takes around 5 years to normally get a vaccine. And then here, the bottom part of the slide is a schema on how they're all trying to figure out how they can do a COVID vaccine much more quickly. And it really comes down to overlapping the different phases. So, and then indeed linking the production and large-scale manufacturing capability very early on, so that if the preclinical trials look good, they can quickly go into safety and dosing trials, quickly do safety and efficacy trials, and have everything scaled up for manufacture as soon as there are one or more candidate vaccines. And of course, a very, very rapid licensing and approval process. But we should never underestimate the challenge of even this whole process. And even the manufacturing is such a big deal. I was listening to a very interesting podcast with Bill Gates, whose foundation is coordinating and supporting financially a lot of this work. And he pointed out that the world does not have enough glassware of a suitable quality for all of the little vials for 7 billion vaccines. So it's down to that kind of level of challenge. So what I'm thinking, to be honest, is that if we get a vaccine within a year, it will be a miracle, and we all, of course, want that to happen. But I think we have to be ready for there not being a vaccine ever, or there being a vaccine over 1 or maybe 2 years. And it is not going to be, it's unlikely that it will be a rapid and complete solution. There's been a lot of discussion about testing, and people have been reporting proportions of people who have been found to be positive in the community. You'll have heard of serology studies in the US. What I would do here is direct you to some online tools, which are quite interesting, that you can play with to look at how useful testing is when a condition is of very low prevalence. So here's a population of 1,000 people, 20 are infected, 980 are not infected. If we imagine that 2% so here's the 2% that are infected, and if we run an antibody test that is 90% sensitive, 95% specific, and that's about what they are, many of them, certainly at the moment. The question is, how good is this test to identify these people? And this is the answer here. That test will correctly identify only 18 of the 20 people that are infected, but it will find 47 people who are not infected, but the test will say they are infected. So this, you can see, is a major problem. And if you use this test for a serology survey of a population, it would massively overestimate the number of people that had been treated with COVID. And this test would miss 2 of the 20 people that were infected. So my point here is it's really important to remember that even if tests are reported to be 95% specific and sensitive, which is a very good test, in a low prevalence situation like COVID in Australia, these tests are not necessarily accurate in terms of measuring. So be careful about interpreting the stuff you hear, particularly in the media, and wait for proper scientific review. I did mention this study last week, and I've been looking more this week at pre-symptomatic or in fact asymptomatic cases. And again, in this case in the US, a little bit like we've seen in the cruise ships and the warships, in these kind of situations, and this is what's happening in New South Wales at the moment in an aged care facility, is about a third of these people are being infected, and about a half of them have no symptoms at the time of testing. A similar study has just been published in JAMA, which looked in a large homeless shelter in Boston. So you can imagine, you know, a large number of men, mainly men, in fairly cramped conditions. And again, in this case, somewhere between a third and half of these men were COVID positive, and all of them were asymptomatic. There's some very interesting and quite troubling work has been published just in the last several days in Nature, Nature Medicine, which has modeled the transmissibility in this pre-symptomatic period. Now, very important to say that this is modeled from swab data, but the researchers found that the highest viral load, if you look here on throat swabs collected at symptom onset, and the loads rapidly declined during the next 7 days. So they are estimating that up to about 44% of secondary cases were infected in the 2 days prior to the onset of symptoms. So again, it's not definitive yet. More studies are needed, but there is evidence starting to accumulate that asymptomatic, pre-symptomatic people with COVID are indeed infectious for at least 2 days before their symptoms arise. Now, the implications here, of course, is that it is social distancing and personal hygiene that reduces that risk. By definition, testing won't do it. Screening for symptoms won't do it. And this is why I think we are going to see strict social distancing for quite some time, no large gatherings for quite some time, not least because of this risk of transmission in the pre-symptomatic period. Now, I do just want to close off with a reflection on some interesting work that is being written about in Australia, but particularly in the UK, but also the US. And this is relevant to where we are in Australia, because there is a lot of discussion about how strict does a lockdown need to be effective. Nobody is arguing about the need for social distancing, personal hygiene, maybe some selective closing of businesses and schools and universities, etc. The question is, how severe does a lockdown need to be? And despite what a lot of people say, there is no clear evidence on this. There are all sorts of anecdotes and case studies, but there is no clear evidence. And there's no clear evidence from COVID yet. It's still too early in the pandemic to get a really clear measure on what is happening. But have a look at this slide. This is London, Birmingham and Manchester in the UK. And this is measures of mobility from their city mapping service. So normally, of course, up here, they're running at 100%. When self-isolation was encouraged in early March, even then, numbers were dropping. Mobility was dropping. Social distancing is encouraged, and, social distancing is encouraged, and the mobility is dropping even further. Schools are closed. Question is it really the schools that are closing here that matters? or is this just the effect of social isolation, social distancing? And then the full lockdown occurred in the UK, where essentially everybody has to stay at home apart from getting out for just the odd shopping and essential medical services. And the big debate is, did they have to go this far? Did they have to go this far? Or would all of this actually have had an equally good effect? Again, the reason I raise this is relevant for us in Australia, because the question is, how much can we ease the restrictions that we are all living under now, and how quickly can we ease them, and how much COVID will there be as a consequence of that easing? So I wanted to bring this to everybody's attention. Thank you very much.
Thanks, David. Excellent summary and update as usual. There's 4 questions that we've come in through Zoom, through the Q&A, and please, anyone who's listening, please feel free. But we are also live streaming on through the HealthCert Facebook page, and I have a question that's come in there. So I'll just read that one out first, David, and then you might be able to have a look through the ones in the Q&A. This one is, what's your opinion, David, about new research published in the New England Journal of Medicine about the association between COVID-19 and ST elevation, MI, and the increased number of confirmed strokes?
So, you know, I'm not an infectious disease clinician. I'm not looking after patients with COVID, thankfully, but I'm reading all of this research, and it's fascinating and quite worrying to see the extraordinary range of syndromes, clinical syndromes, that can occur in patients with COVID. So I think that I would point colleagues to the Brigham and Women's website that I showed earlier. If you want to have a look at the latest thinking on what the clinical syndromes are. It is clear, talking to doctors here that are looking after patients with COVID, that they're seeing a range of syndromes that are quite bizarre and not at all typical from other viral infections. So I think it's a case of watch this space and see where that takes us. And I think it's the same with Mayo's question there about the macule and papule on the toes. You know, is this a reduced platelet count or the virus itself? I mean, again, this virus is clearly causing some weird thrombotic episodes of a whole range of different types, and to my knowledge, nobody really knows exactly what all of that is yet, and the clinicians are still figuring out how to treat these particularly sick patients. So again, I think it's a case of watch this space. The next question comes down to, you know, I guess really here from Kishamendra, is really about the safety of clinical interaction. What I would say there is, as much as I've said before, you know, the levels of COVID in Australia now are vanishingly small. And I think it is completely safe, or as safe as it possibly can be, in primary care, in general practice, in skin cancer clinics. I would certainly not be consulting patients who are symptomatically unwell. Now, I know I've just talked about the importance of asymptomatic transmission, and that is there, but we can only do what we can do. So I think we continue to exclude patients who are symptomatic, and I think we continue to do a skin check with dermoscopy. And, you know, many doctors are wearing masks and want the patients to wear masks, and that's fine. We've talked about that in the past, about if you're going to wear a mask, wear it properly. The truth is that even on patients with lots of skin damage, you are not spending a lot of time with your face close to their face. And so I think that particularly in our circumstance in Australia, is now safe. That wouldn't be the case in the UK. It wouldn't be the case in the US. A very good colleague of mine has an elderly parent in Scotland at the moment. He has a leg infection, her father. He was managed by their GP in his car, in the car park of the practice, because it was dangerous to take him into the building. We're over all of that. We're over all of that. And so I think basic sensible precautions is what we need to do there. Alison's question is, in the absence of a vaccine or immunity, what are some possible scenarios of how we'll coexist with the virus? I mean, Alison, it's exactly the question. I think at the moment, so I would answer it this way. Nobody knows what the future holds. Will this virus fade away? Probably not. Will it come round and round and round in waves? The second wave, the third wave? Well, it could do, it's possible. And if we all stopped the good things that we've done, then it probably would. That's happened in other parts of the world. What the government is trying to do here is get to a position where there is a low level of COVID, a very low level of COVID in Australia. If there is a bit of an outbreak, a case or a little outbreak, it's jumped on quickly, it's identified, testing, contact tracing, quarantine, maybe little lockdowns of parts of the city or a country town or whatever it might be, and simply having to accept, like with all the other infections and diseases that we all live with, that there is a new one, and it's called COVID-19, and it's kind of with us all the time, but at a low level, while all of the effort continues in the long run for a vaccine. The issue of herd immunity, you know, I mean, we don't know that yet, right? We don't really know how much population immunity is needed. People talk about 60, 70%. Well, it's a long way from that in any country. So herd immunity, long way off. Vaccine, long way off. The lucky thing is that for most people, remember, 80 to 85% of these people who become infected have a mild illness, and almost always severe illness is in the elderly and people with comorbidity. So I think we're going to have to find a set point with life with COVID. And I think we're going to see social distancing, significant restrictions for quite a period of time. That's my best guess. It'll be very interesting to see what happens as restrictions are lifted in the next few weeks. And but it's very clear, talking to the Chief Medical Officer here in New South Wales, that the expectation is there will be cases, but it won't be too many. And we've got the health system to give the best care to all of them. And we're all going to be living with social distancing, much less travel, certainly no international travel for other than New Zealand, perhaps, for months. That's kind of the new normal, I think. And then Monique's question concerning Kawasaki disease and children, thinking around school-age children and their young siblings at home. Yeah, so I mean, there have been a number of cases of Kawasaki-like syndrome in children with COVID. As far as I know from my reading, no cases in Australia, but we have such small numbers, you wouldn't expect that. Look, the reality with schools, if you look at the evidence, if you look at the data, Monique, it goes like this. the risk to children themselves is incredibly small. It's not zero, but you know, it's not zero in the bus or the car going to school, or you know, any number of other conditions. It is incredibly low risk to the children. The greatest risk is spread amongst teachers and spread between parents and teachers, and that's a much greater risk. And then of course there is risk, there is certainly risk, but it's low risk that children can transmit to, for example, elderly grandparents. So the truth is, for the very large majority of cases, I've looked at this data very carefully, because of course we're having to make decisions about this for the university. We have 40,000 students waiting to come back to campus. Now, they're not school children, they're young adults at least. So, but we have to understand this research very carefully. I'm quite sure that that schools are safe, safe enough, very, very safe, and that it's, you know, children should be going back to school. I have no concerns about that. The safest people at school is the children. Teachers have a bit of risk. They must socially distance. They must use hand hygiene. Hamish? I think we're done.
Yep, thank you. Yep, no other questions from the web or in Zoom. So thank you very much, David. Excellent. We don't have a business related medical business seminar this Thursday. We're having a break. So David, we'll be back with you next Monday, which I checked in is going to be the 11th, which of course is restriction lifting day, apparently. So there may be some things to talk about. I mean, just one thing, as you were talking about some of the different, the lifting of restrictions, and I think one thing that for international travel, I think we're going to need to get used to the contact tracing app idea. I think Australia is going very softly in the sense of making it optional. But I would expect the next time that I travel to the UK, potentially the US, and certainly China, a condition of entry will be to show that it's installed some kind of tracking, because the way that China is managing COVID internally is to have a compulsory contact tracing app in a very much more proactive way than we would ever imagine, where the app actually shows your status in a red, yellow, green basis based on who you've been nearby. And if you're yellow, you can't travel outside a certain area. And the app automatically updates if you have been within a certain range of someone who also was yellow, or those kinds of things. And I know I just recently saw the UK were also potentially tying restriction lifting in June to some kind of tracing app. So I think
so let's make it a topic for next week. The head of cybersecurity at Macquarie University is a member of the advisory panel for the COVID app in Australia.
Okay.
He is an arch skeptic. His whole issue is around privacy with cyber data. I know him extremely well. I will spend time with him this week, and I will report back in detail on that topic amongst others next week. Hamish.
Yeah, thank you. That would be interesting. All right, thank you, David. Thank you, everyone, for joining us this evening. Again, this will be recorded and sent to you to forward to your colleagues, and we look forward to seeing you next week. Thank you very much.
Thanks.